Good afternoon. I'm Aaron Levo. I'm the Vice President of Communications and Public Affairs, and pleased to be playing a moderating role as usual for today's HHS Town Hall. So today is Thursday, April the 21st, and as I said, we have a packed agenda with lots of what's going on across our organization, including Project Odyssey, and an update on the pandemic as well in our operations. So just before, a little housekeeping before we begin. If you do have a question that comes to mind throughout the course of our presentations, you can email that question to hhsnews@hhsc.ca, and we'll put that email address up a little later for you, and we'll also have that available on the hub. As always, it's really the best way to get an answer to a question or make a suggestion. One particular reason is we actually know who you are. So we're able to follow up with people directly. So I know we have had questions posed during our celebrations, which is our custom to have at the end of our presentations. And it's sometimes challenging, even if we have a person's first name, to know exactly how to get a hold of them. So really the best way to pose a question or make a suggestion is through the email inbox, simply because we can follow up. And I know we have in the past and do quite regularly. So that's great. And as I noted, we will have celebrations at the end. So please, as you're hearing our presentations today and thinking about what's going on in your work, think of those people, teams, or occurrences that you'd like to celebrate. And we really hope that you'll do that at the end of our formal agenda. Okay, so that's enough out of me. Our President and CEO, Rob, couldn't be with us today, but I'm pleased to have Sharon Pearson filling in. Sharon's our Chief Operating Officer and EVP Clinical Operations, and is going to give an update and kick things off. So Sharon, over to you.
Great. Thank you, Aaron, and good morning, everyone, and happy to be here and subbing in for Rob today. So I'll start with our land acknowledgement. We're privileged to provide care on the lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. So some good news to share with you this morning in my update. Many of you probably heard, hopefully saw the news last night and perhaps saw in person that Health Minister Christine Elliott was at the Juravinski Hospital yesterday for a very exciting announcement, really two announcements regarding our Juravinski site and our Hamilton General site. Firstly, we received the green light along with the funding, the necessary funding, to continue our planning for the redevelopment of the oldest parts of the Juravinski. So for those of you that work here, you're well aware of those, but for those that don't, it's the E, F, H, L, and M wings that will be renovated, but brand new tower, and also renovations to the emergency department, diagnostic imaging, and the surgical area. So a massive redevelopment at the Juravinski site. The plan that is in place will see a 70% increase to the site's footprint. And much of that is because the standard now for hospitals is single rooms, or are single rooms. So the planning will get underway this fall with an anticipated completion date of 2029, which will come, seems a long way out, which will come very quickly. And when the doors open at the new Juravinski Tower, this site will be the largest inpatient hospital in the region. So a massive undertaking that we're all very, very excited about. Secondly, Minister Elliott also committed funding to support the expansion of the emergency department at the Hamilton General Hospital, which is very much in need. So the plan will increase the footprint of the existing ED by up as much as 50%, and it will greatly improve the layout and the flow for anybody who works there or has been through that department. Updates will include renovations in the waiting room, a full decontamination suite, and increasing the number of patient bays. So this really is critical for us to be able to deliver the care we need to at the Hamilton General and manage the flow and activity we see there. And hopeful that we'll start construction at that site in 2023, which is very, very much in the near future. So this is all great news for all of us here at HHS, and certainly for those that work in the areas of the JH and certainly the ED at the Hamilton General. And we'll keep you posted and apprised of the developments with these capital announcements in the upcoming months. So I'll talk a little bit about hospital operations before we go on to the rest of the agenda. So in terms of where we're at with our COVID numbers, you can see they are higher than certainly what we saw a month ago. So we have 90 patients now, only 5 or less than 5 in the ICU, but we do have 3 active outbreaks. We have 288 staff in self-isolation, and I know that our health human resource challenges are felt across all of our clinical and support areas right now with the numbers that we see self-isolating and off ill at this time. It is reflective, the volumes that we're seeing in our occupancy. So you can see our overall aggregate midnight occupancy was 107%. Would remind everybody, a good occupancy rate for a hospital is more like 85 to 90%. So we're well above that. And then you can see at a discrete level across our acute sites, the occupancy rates that we're running. So West Lincoln at 133% this morning, which is an inordinately high occupancy rate. JH at 120, Mumsy certainly above 100%, and the Hamilton General at 106. So all very pressured sites, and I know that's in relation to the challenges we have with some of our discharge processes, along with the volumes we're experiencing and the acuity. We've also seen our ALC creep up slightly. So if folks are remembering some of the numbers I've reported out previously, at one point we were as low as 160 ALC patients. We're now above the 200 number. If we could go to the next slide. Because of the pressures that we're experiencing, we are challenged to ramp up in terms of our pre-COVID surgical and procedural activity. We did get above the 70%, closer to 80% about a week and a half ago, but we've had to reduce back to 70% because of the health human resource pressures that we have. We also need to always be cognizant that we have to remain accessible to our regional programs and also respond to those that arrive in our emergency departments. While we continue to do the system planning and having conversations with our partners across the region and really across the province, every organization is in a very similar situation, feeling very stressed and feeling the pressures of the HR impacts that COVID is having. So again, our ramp up will be very slow and it will be a very gradual process. We will aim to try to get back to the closer to 80%, but it will be into May before we see that number. In terms of what we're trying to do to reduce the pressures on the sites, again, I talked about this last week. We're really trying to maximize our throughput in our post-acute facilities, satellite health facility, the St. Peter's, and also beds that we operate within the community. Across the organization, we've really tried to augment some of the discharge planning processes on those units that have the complex discharges. There's also a committee that's been established within the HBB with our partner hospitals to support barriers for those most complex patients that are challenging to transition either to long-term care or to community beds. And again, many partnerships ongoing with the community as we look to see how we can really optimize any available capacity that exists within the community. So, many thanks to those like SE Health, Good Shepherd, Able Living, who are very good partners that we continue to work with. And a lot of effort on really ensuring that we do good discharges, supportive discharges, try to avoid the readmissions, and try to avoid the revisits back to the ED department. So I know the teams are working incredibly hard in order to try to reduce the pressures that we're all feeling. And I do thank everyone. I know it has been a challenging week coming out of Easter with the pressures that we have. And with that, I will hand it back over to Aaron for the remaining part of our agenda items.
Thanks very much, Sharon, for that update. Next up on our agenda, we have Kirsten Krall, our VP Quality and Performance and Chief Nursing Officer, who's going to give us an update on a corporate project around workforce planning. So Kirsten, over to you.
Thank you. An exciting update from Sharon around the Juravinski site, which obviously is important also from our health human resources perspective as well. We do have a focus on this as a priority as an organization, and a steering committee came together around September of last year to get going with a work plan, and that work plan will continue to develop. There are hot spots in particular that we're honing in on. We can't look at everything related to health human resource pressures in the organization. They're quite widespread. And I'll just say, it's certainly not only HHS. All of my C&E colleagues in the States are having similar dilemmas to us. So we are not alone, but it is, of course, something that we need to step up our game and find new ways of doing things to really try and find a better balance. We do have hotspots, though, that we are focusing in on nursing roles in particular, such as the OR, the ICUs, even including PICU, pediatric ICU, NICU as well, oncology medicine. So those are some of our real hotspots that we're really trying to understand what can we do differently to improve those pictures. Respiratory therapy is another focus. Pharmacy techs, DI, and some of the specialties, particularly MRI. And even our physician workforce as well, anesthesia and internal medicine surgery are some of the dilemmas that are on our radar to try and look at ways of addressing this. So we are trying to approach it with a model that's looking at issues around recruitment, how do we look at work redesign, and then focus on retention as well. Retention, of course, very much even influenced by the whole issue around our success of recruiting people. We need more people to fill these vacant positions that exist in the organization. And of course, some of these vacancies that we do see in the organization are demographically related. Some of these things were looming before COVID even started, or the pandemic happened worldwide. These comments about some of the pressures in healthcare were already looming in many parts of the world. So of course, got exponentially impacted as we've been moving through the pandemic. And again, how do we start to focus on some recovery? So that's what this work is all about. So I'm co-leading that as an executive sponsor and chair of the steering committee, along with Michelle Leroux, who's here today as well, but I'll do the presentations, but she's also available to us if there's questions and so on that come up, or more that she'd like to add a little bit later. So thanks, Michelle. So we're really focusing also on the data, because we have a recruitment software system and we also have Chronos, we are now able to actually pool a lot more information together to understand some of the patterns that we're seeing as far as our workforce across the organization, number of vacancies, how much time it takes to fill positions. We're even starting to get a bit of a handle on how many applications come through and what is kind of the proportion of applications to hires. And can we start to look at not only existing today, but what can we start to eventually forecast down the road? So we're getting much more sophisticated. It takes a bit of time, but the good news is that we've got a lot more tools at our fingertips now because of lots of investment over the last couple of years that really has powered up our ability. And of course, we'll eventually be able to marry some of this information with what we'll get from Epic. So it really will help us to understand what we're really needing to try and plan for. So that's great news for us as well. The strategy is really planning for how we use best practices. So we're looking far into the literature, but also other industries and so on to really understand what could we be doing differently. And really, it is a time where we have to be bending the rules around how we think about innovation when it comes to health human resources. So we'll always be open to new ways of thinking and feedback from people around how we could be doing things differently. And then we are trying to enhance the talent acquisition. So we do have, as an example, a bit of a pilot going on right now around a centralized recruitment model for nursing. Again, it's a team anchored with HR, where they are really trying to work with the leaders on the units and so on, and trying to really hone in on recruitment strategies. PR and comms are doing great work as far as campaigning, and it's really helping us to bring people through the door. We've had some virtual nursing job fairs as well, which are really gaining some interesting experience around how to make those work well, how can we expedite interviewing and offers as well. So really trying to streamline, use our best CQI thinking around streamlining processes, but also how do we reach people? And we know people of HHS, it matters that they talk about their work, their organization, and opportunities here as well. So the human connection is really important, and how do we optimize that? So looking at all sorts of different strategies to enhance that talent acquisition. And of course, our schools are an important part of that process, as well as we connect with our future workforces that are coming through the school system. Next slide, please. So we are definitely thinking about these workforce pipelines. Our clinical extern program is a great example. Ministry of Health investment into the extern program. We've had over 300 people go through the extern program, and this is where we've got learners, could be in second, third, and fourth year undergrad, where they are actually hired on as non-regulated care providers, along with our team members who are providing that preceptorship. but they are paid as part-time employees to really gain some of that experience. And we also have formal roles in place, a great team of preceptor or coordinators who are helping to mentor individual learners. It's really great that the externs are getting some really interesting experiences, but it builds some of that confidence and familiarity, and they start to get more exposure being part of a team. So this is a really important pipeline for us, a great success story, actually, not only at HHS, but across Ontario. The international professionalism support that we're providing as well. We have our International Educated Nurses program, and again, some changes with the College of Nurses that allows us to help international trained nurses to get more of their practice experience qualifications that they need for their registration, to acknowledge that through something like an externship program at HHS. So that's great. We're also looking at alternative international professionals who have had some micro-credentialing and so on through Mohawk College. So again, we're trying to look at, are there different paths that we could create for individuals who are trying to get landed here and working in their profession. And we're focusing on grow our own professionals. We know we're going to have to look at how do we traverse people through career paths from assistant types of roles over and eventually into more professional roles with qualifications, and then even advanced practice as well. So again, how do we look at career pathways and competency models to grow our own professionals? So there will be a lot more emphasis on our organizations taking some focus on this. And there is a big focus on work redesign as well. We've got 6 areas that are part of work with our quality and value improvement team and a few of our chiefs and so on, and folks from NRT, looking at how we could maybe think about redesigning work. And it's really to kind of think of where are there things that maybe professionals are doing things that could be done by some alternative roles, and really allow that professional to work to full scope and not have to worry about other things that might be consuming their day and become it's important work, but it could be done by others. So again, where there may be some opportunities to that is what that work is about. So more of those opportunities with even the schools and development of micro-credentialing programs. We've got examples with our OR assistant role. Again, something that's just a pilot really for us to understand, and great work going on there. But again, it's a learning for us, right? Or even things like a pharmacy assistant role. Again, things that, you know, in past, maybe we didn't really have to contemplate, but our population needs care, and we do need to find some alternative ways to redesign that work and get that care to the people of our communities. And finally, big focus will happen on retention. And this is, of course, multidimensional. We are taking advantage, of course, to all the engagement survey results and making sure that, you know, areas continue to focus on how can they continue to engage people. Very tough to do, I know, when people are working so hard and really trying to take on so many different functions, but engagement's really important, the resilience work that's happening. How do we help people have the connections to each other? Even leader capacity matters in this, right? We know from retention feedback that we've had internally and also from the literature, you know, leaders make a big difference on how teams are functioning. And if they don't have the capacity that they need to do their work well, it's very hard for them to really create that environment, that climate that we need for teams to stay strong, resilient, and focused on all the things that need to happen for success. So retention will have a lot more updates happening on that, but it is multidimensional as things go on. So we are looking also to try and get some external help to really put a robust work plan together to take us into the next few years as we think about workforce planning. This is not an easy fix. It's going to take multiple strategies and quite a bit of effort. But I have to say thank you to many people in our organization who continue to provide great mentorship to learners, to a lot of new employees. And really, I'm very impressed and always inspired. We had bursary awards last week for a number of folks. And again, you know, many of you also put lifelong learning to work in advancing your careers. So thank you for all of that effort in times that are quite strenuous for everybody, but so important for us to continue. Okay, so on that note, thank you, and over to you, Aaron.
Thanks very much, Kirsten, for that update today. Very informative. Next on our agenda, we have Dr. Dominic Mertz, who's our Medical Director of Infection Prevention and Control, to give us an update about what's happening with the pandemic across the country and locally. Dominic, where do we sit today?
Yeah, thanks, Aaron. And I think it's again a mixed bag, but quite the opposite than of what I would have reported 2 weeks ago, where things looked more quiet locally, but more active provincially, and now it seems to be turning around. Given that there's a lot of attention to wastewater, I decided to show you a couple of slides on wastewater testing here as well. So this is the provincial wastewater signal for COVID-19. You see that based on this, we may have peaked roughly 2 or even 3 weeks ago with a slow decline at this point. But as you can see on the next slide, what we see in wastewater varies a lot across the province. You have the effect of a decline mostly driven by the GTA and Southwest, North relatively stable, Central West, that would include ourselves, we seem to be plateauing at this point, while in the East, things are still increasing in terms of wastewater signals. Now, all of this being said, and showing you on the next slide, the Ottawa wastewater, where you can see the wastewater in the with the orange line and the hospital account in blue. You can see that it's not necessarily as predictive as we would want it to be. Wastewater signal in Ottawa has peaked at more than twice of what it had been back in January, but hospital admissions remained at a third of what they had at peak in January. So there's still question marks around there to what extent it is predictive of what's happening in hospitals, but I just wanted to show you the trends at this point of time, so it might be easier for you to interpret when you're reading in the media about wastewater testing. Comes with a question mark, but we see a clear signal change at this point of time. Next slide. Staff absenteeism from COVID-19 is another metric that we can use, in our opinion, instead of the case numbers out in the community, which, as I repeatedly mentioned in the last few months, aren't really representative anymore. What you can see here is that since end of February, we first saw a slow, then a faster increase in staff absenteeism that may or may not go into a plateau at this point. You may have read last week, there's been some data on provincial staff absenteeism in healthcare, which has peaked. So it looks like we are lagging behind there, and I will show you other metrics where it looks like we are lagging behind the province. On the next slide, I just give you those like timelines in terms of what we did from a public health perspective. And on the next slide, you see when earliest we would expect an impact of those measures on our staff absenteeism. So that this is roughly a week, and that's like the earliest that we would expect a change, because that needs, first you need to transmit, then staff needs to develop symptoms, then get tested. So a week is the bare minimum. And how this aligns with staff absenteeism. And the one piece that I just want to mention is, if you're looking at that, it's not as straightforward as because of ending the mask mandate on March 21st, we see that increase. The increase started well before that. Next slide. In terms of hospital admission, these are the provincial numbers. You see the numbers are still increasing. It's increasing at a lower pace at this point. Next slide. We are sitting now where we've been like in winter 2020, 2021 at the January peak back then, or higher now than January 1st, 2022, when the first Omicron wave hit us. But you can also see, and again, re-emphasized on the next slide, what I've already shown you last week. Yes, we absolutely do see an increase. The slope is different, and you can see that when you look at the last data point, which may still change, but it looks like the slope is decreasing at this point, that we had the highest increase over the last 2-3 weeks, and now it seems to be slowing down, hopefully, and fingers crossed at this point. Next slide. this is the Hamilton data, and that's where we are also lagging behind. So when I presented 2 weeks ago, I mentioned that we are one of the outliers in the province where we haven't had or haven't seen an increase in patients with COVID in a hospital yet. And this certainly changed over the last 2 weeks, as you can see now, and already Sharon shared you some data on this as well. Next slide. Out of those patients at HHS that are currently hospitalized with COVID-19, 35 are considered having a primary diagnosis of a respiratory infection, including COVID. The remainder are, and unfortunately a very similar number, are outbreak-related cases, and the remainder are incidental positives where we wouldn't have expected COVID. Or they have minor symptoms and are in hospital for other reasons. As I mentioned previously, all of this comes with a grain of salt because it's not as black or white, but just to give you an idea of what we are seeing across the hospital. Next slide. ICU admissions, today 203, yesterday 198 at the provincial level, hovering around 200 over the last 4 days, but before that there was certainly an increase. Next slide. And this increase again looks very different from what we've seen with the first Omicron wave, end of December, beginning of January. But I don't think we are at the peak yet. But again, if the trend from the last few days holds true, we may be peaking earlier rather than later. Next slide. ICU admission in Hamilton, stable at this point. Now, again, keeping in mind that we might be lagging behind the provincial picture, we may only see the increase in the next week or two, or this might be the level that we remain, and I will come back to that when we are looking at the models for Hamilton. We are sitting where we've been sitting early January 2022, or during the Delta peak, or post-Delta peak, I have to say, mid-October 2021 at this point, but with a much, much smaller number of vented patients than we've ever had since end of 2020, actually. Next slide. These are the provincial predictions from the science table for March 17, and as you can see, it's quite linear in terms of increase over the last few weeks, but certainly higher than what had been expected. And they revised their models, and you can see that on the next slide. By April 14, these are the predictions for hospital admissions, which go into the range of where we had been at peak in mid-January, depending on which scenario you pick. The good news here is we are actually running better than the best case scenario. So probably the truth will be somewhere between that best case scenario and the previous model, the outdated model that I've shown you previously. Next slide. In terms of ICU admission, I only show you the latest model here. We are also doing much better, well, not much better, but better than predicted at this point. As I said, hovering at around 200 patients in the ICU at this point, which is at the lower end of the range of what had been considered as plausible scenarios. Next slide. Switching gears to Hamilton, here you see our hospital predictions, which are expected to continue to slowly increase into mid-June. They are based on the latest scenarios shared by the end of March. And you can see that we pretty much follow that base forecast here, that blue line at this point. Next slide. Similarly for ICU, we've done better than expected for a week or so, and now we are pretty much back in that range of what's been predicted, which is roughly one hospital admission, one ICU admission of a Hamiltonian every other day, so 0.5 per day. Next slide. So in summary, I would say that provincially, we probably peaked 1 to 2 weeks ago based on what we see in terms of wastewater, staff absenteeism. A number of outbreaks seem to stabilize as well. Hamilton may be lagging behind the provincial trend by maybe 1 or 2 weeks. That's to be determined. One concern is obviously the effect of the long weekend, which still needs to be determined. Do we see a second peak? Do we see just a slowed down decline? Do we see a shift to more vulnerable population? And one of the reasons why we probably haven't seen an awful lot of ICU admissions so far is that Omicron first and foremost spread among the not as vulnerable population. So mostly parents, their kids didn't get as much of a foothold maybe so far in the over 65-year-old population. And this may have changed with private gatherings over Easter or may not. Let's wait and see what happens. But that's certainly some level of uncertainty that we have at this point of time. And as I mentioned, likely locally, we haven't peaked in terms of hospital admissions yet, and we may see a further increase. The good news is when you're looking over the last week in terms of number of outbreaks within the city, it has stabilized in that range of 25 to 30, which is much, much better still than where we had been in January with more than 100 outbreaks. So if we use outbreaks as a sort of as an outcome of the risk that we see in the community, it looks like things remain sort of under control and manageable at this point of time. Thank you very much. Handing over back to you, Aaron.
Awesome. Thanks very much, Dominic. Very informative presentation today, as always. So next up on our agenda, we're going to talk about Project Odyssey, which is winding its way to the go live date. And to help us navigate that today, we have Carissa Corden, who everyone will know is our Chief of Nursing Practice and also Chief Nursing Information Officer with Project Odyssey. Carissa, what do you got to tell us today?
Thanks, Aaron. Good afternoon, everyone. I'm here to give you some updates on Project Odyssey. And as Aaron mentioned, we are well on our way in our journey for our go live on June 4th. Only 43 days away, and we are getting close. Next slide, please. Next slide. Many of you would have heard about high impact workflows. These workflows include operational processes or practices that will fundamentally change when we go live in Epic. We need to know these workflows really well, as it can have patient safety or service delivery implications. At Go Live, we're actually excited because now we're going to ensure that we're providing safe patient care to our patients. All of the resources on high impact workflows are posted on the hub for you to review, which include slide decks and tip sheets. Demo videos are posted on the learning management system as well. And we also invite you to attend our interprofessional practice rounds where we will review these workflows. This week, I'm here to briefly discuss the allergy high impact workflow. Allergy reviews refers to medication, food, and other allergy review workflows on admission or clinic visit, including changes to allergy armband. In Epic, patient-reported allergies are not collected at registration. Instead, this information is collected and reviewed on admission, and all providers, nurses, pharmacists, dietitians, and other health professionals will be able to enter or update your patient's allergy status. Red allergy armbands will be used as a visual cue to complement the process during go live. Continued use of these will be reviewed after 6 months. Allergies from previous admissions and clinic visits will require review at each visit, and the system will alert the clinician if the review is not completed or if there's a contraindication due to allergy. So please take the time to review the allergy high impact workflow by reviewing the tip sheets and demo videos available on the hub and on the learning management system. And think about how this high impact workflow fits within your day-to-day practice. Next slide, please. Labels and armbands are also changing when we go live with Epic. These are important supplies to have, especially as we move towards barcode scanning for medication administration, blood products administration, and specimen collection. All clinical areas where patients will wear armbands will also require new allergy armband supplies. All of these supplies must be ordered by Friday, April 22nd. We're asking managers, service coordinators, and clerks to please order labels and armbands by tomorrow to ensure that they arrive in time for go live. We have also provided tip sheets for this, and this is available on our hub. Also, as a reminder, many of you have participated in the design of our EPIC system, so thank you for your participation. Our Odyssey and EPIC team have completed their build and testing, and this is a great milestone for our project. With over 2,000 engaged staff and physicians collaborating across dozens of work groups, HHS version of EPIC is built, and all testing have been completed in time for our go live on June 4th. As teams begin learning about how the system works and sees its potential, we remind you that no changes will be permitted until stabilization occurs. We expect this period to begin approximately in the late fall of 2022. Requests for enhancements or ways to improve EPIC's functionality can take place at this time. We also have some upcoming activities underway, which includes patient flow days, shadow charting, user setting labs, and organizational readiness days. For, sorry, can you just go back one slide? Go back one more slide, please. Training. Please review your assigned e-learning prior to attending your first in-person training session. Staff and physicians who receive the information about in-class training are required to attend their training, their assigned sessions. Once you've attended your classroom training, you will be provided with login information. Information for access to the EPIC Playground is available in Citrix, so please keep practicing. For our leaders, please review the memo on rebooking missed classes, and please register any new employees for training and assign them to their appropriate training tracks. We're also asking you to please keep reviewing your training dashboards to track your team's progress. COVID is having an impact on training attendance and scheduling, and we're asking for your patience with any changes to scheduling and/or processes that may result in this. If you have any questions, please email our EPIC training email at epictraining or providertraining@hhsc.ca. Next slide, please. We also have a few more activities planned in April and May to get us ready for go live. So first up is shadow charting. This is a readiness activity that will only impact a select number of units at HHS. These units have been tasked with charting in the HHS's legacy system, like in Meditech, and EPIC beginning tomorrow. So shadow charting enables the Odyssey team to test out the new system and identify anything that may be broken or missing before the entire organization starts using it. While not everyone will be directly involved in shadow charting, it is an important readiness activities that benefits everyone at HHS. So please be patient with any direct or indirect impacts of shadow charting on your work. User setting labs for our provider groups for physicians, nurse practitioners, and midwives are also underway. This is an opportunity to get our providers into the production system prior to go live so that you can customize your workspace to make go live more efficient. You'll be trained on Dragon Voice dictation, and we can also help you set up your haiku and canto. Other activities include organizational readiness days on April 27th. And so we're asking all of our leaders to please endeavor to attend this day. For May, we have a few other activities planned, such as our 30-day Go Live PEP rally. All of our staff and physicians are encouraged to attend. Shadow charting will continue in select units. We also have workflow dress rehearsals planned in select areas. This is a fun event to test our various workflows, including admission, transfers, bed booking, adding provider teams, administering medications, and printing after visit summaries. For some of our leaders, please attend our Go Live Readiness Assessment Day. This is our 30-day GLRA. Again, in-class training will continue, and we're also going to be offer super user refresher training. And that is the end of my update. If you have any questions, I would encourage you to please email odyssey@hhsc.ca, follow us on Twitter, review resources on the Hub, and ask questions. I'm now going to hand it over to Aaron to lead our question and answer portion.
Thanks very much, Carissa. So yeah, if anyone does have any questions that's come up, we've covered a lot of ground today, and we certainly would welcome input and questions, and we can get an answer back to you quite promptly if you use the HHS News inbox. So the email address is in front of you. It's also accessible on the Hub, and you can email any questions that you have or suggestions to hhsnews@hhsc.ca. Okay, and as is our custom, we'll conclude with celebrations. It's an opportunity for our panelists and our participants to either raise a hand and give a shout out live, or you can type it into the chat forum and I'll read that out for you. So anything that you'd like to celebrate, now's the time. Leslie Gillies, I see you with a hand up. What would you like to celebrate today?
Oh, thanks, Aaron. Just a sincere appreciation to the Odyssey team and our staff and physicians and leaders at West Lincoln. Today was the kickoff of the patient flow day, and attendance and appreciation, despite such sort of intense bed pressures as we've outlined, is absolutely appreciated and valued. So thank you so much. Great participation, great attendance, and great questions brought forward. Thanks all.
That's great. Thanks very much, Leslie. I see Kareem Tony with a hand up. We'll get back to you in just a minute, Kareem. I know sometimes people raise their hand in air, and that might not be the case with you, but I'll just read out one while we're here. Looking forward to celebrating National Volunteer Week next week, April 24th to 30th. This is from Morgan Richardson. Excited to welcome back volunteers in the coming weeks and thanking the volunteer resource coordinators for all their efforts to date to make this happen. That's amazing. Thanks, Morgan, for sharing that. And Kareem, we'll go to you now. You should just get a message to unmute, and you unmute and you can give your celebration. So go ahead. Are you with us?
Can you hear me?
Yeah, now we can.
Yeah, thanks. I just want to say congratulations to Dave Morrison, who's had 39 years with the biomed department and is now retiring. So we wish him a happy retirement.
Awesome. Well, happy retirement, Dave. Thanks, Kareem, for making that shout out today. Here we have a quick reminder from Carissa, a quick reminder to please complete the April Readiness Pulse Check survey by tomorrow. So let us know what's going on as well as what needs improvement. So this is for our Odyssey Readiness. You can look for the survey link in Odyssey News or in the Dispatch. So please make time to fill out that survey, always helpful. From Stephanie Furtado, happy Nurse Specialized in Wound Ostomy and Continence Awareness Week this week. Thank you for pointing that out, Stephanie. From Neil Johnson, thanks to the facilities team and many others who have worked so hard to realize the approvals that were announced yesterday for the Juravinski Hospital and for the Hamilton General Emergency Department. Two important projects underway. Thanks very much for that. We also have another shout out here for Dave's retirement that Kareem mentioned. All right, let's see if we get any final hands raised from our panelists or participants. I'm not seeing any, so maybe Sharon, I'll turn it back to you to close us out.
Great, thanks, Aaron. Thanks everyone for joining us. We really appreciate that you would take time out of your day to join in, and we do hope you found the content valuable. And again, please forward any questions you may have about the content or suggestions to hhsnews@hhsc.ca. Thanks everyone, and have a great day.